Yes.
It's my pleasure to announce our speaker today, Dr. George Bud Vana. Bud's work addresses three of RI's areas of focus: fighting disease, saving mothers and children, and supporting education. Bud is a triple boarder, meaning he's taken 3 board exams as a general pediatrician, adult psychiatrist, and child psychiatrist, practicing at the Lummi Tribal Health Center in Bellingham. He and his psychiatric team are integrated and co-located before coronavirus in the medical clinic, the substance abuse program, pediatrics department, school-based health clinic, and the behavioral health department. He finished his BA and MA at Harvard University in Near Eastern Languages and Civilization, then completed medical school at the University of Vermont, and completed residency training at Brown University in Providence, Rhode Island. He has worked to develop telehealth infrastructure at the Lummi Tribal Health Center, as well as child psychiatry consultation service for other tribal health clinics. His other professional interests include family-based psychiatry, acceptance and commitment therapy, treatment of co-occurring disorders, treatment of development disabilities, and integrated medical and behavioral health care. Outside of work, he enjoys canoeing, hiking, and curling, the Olympic kind, with his family in Bellingham. Bud says, "My great-grandfather, Franz Hunt, was a charter member of the Rotary Club of Newport, Vermont, back in August of 1924. Dr. Bud, welcome to the Rotary Club of Bellingham. I'm looking forward to hearing about your amazing work. You have the floor. I assume, Gary, you've given him a presentation, right?
I think so, and I tried to just start sharing my screen. Can everyone see it?
It's working.
Yes.
Okay, great. President Gary, Dr. Goldfogel, Rotarians, and Paul, thank you for having me, and thank you for that introduction. So out at Lummi, and probably generally in practice, I go by Dr. Bud, which is appropriate for a pediatrician, but also out at Lummi where everybody, it seems, goes by a nickname. So that's really helpful. I like to mention that I don't have any real disclosures of financial import, except that really what I'm talking about does not directly represent any of the views of sort of the people I work for, but that my goal is to provide better access to high quality and high fidelity psychiatric care, and to be accountable to the care of the patients and they're improving their mental health problems. I'm just one guy. These beliefs are pretty specific to me, but I hope that they help. So after this, I hope that the audience will understand what some evidence-based prevention strategies are to improve mental health, what some return on investment might be for some of these programs I'm going to talk about, and generally what is missing from some of the treatment options that we have here at Washington State. And I also want to sort of talk about some cycles of how we help patients, both in terms of prevention, intervention, that is sort of when we're actually sort of doing the work and treating patients, but also thinking about post-vention, which is, sort of the debriefing of what did we do actually and how did it work. But big picture, I am going to be arguing that right now you and we are paying too much for mental health care in the state, and that we're not getting appropriate return on investment. And what I mean by that is that we're spending money on mental health care where treatment is not actually happening, oftentimes in the jail or prison, in juvenile detention, sometimes in foster care, and certainly in the emergency room. And that really thinking about where treatment could happen that sort of staves off visits to those places is important. And so when I talk about prevention, it's going to be talking about ACEs, which hopefully you will all be familiar with by the end of this, juvenile justice and racism. Some intervention strategies, including looking at different levels of care, and then also the CAHOOTS program, and then a little bit of postvention that we'll talk about generally. I think about medicine as cases, and I think we've heard about some pretty tragic ones that President Gay was just mentioning. But I'd like to sort of have you all think about a recent article in the Washington Post over the weekend about this boy named Ahab. And so he is a patient who is really 11-year-old, serious mental illness. He's already displaying signs of schizophrenia, hearing voices, and his family has fallen into poverty. And so thinking about him, this Black, mentally ill 11-year-old boy in a pandemic where the resources that might have been available really aren't, and put on top of that sort of his violent outbursts and how they attract the attention of the police and other neighbors and things. And I want to think about him as sort of a test example of how we can provide services in a different way that hopefully meets his needs and doesn't lead to him getting treated in those settings like jail, juvenile detention, and other places. So first I wanted to talk about the prevention aspect and what ACEs are. So an ACE is an adverse childhood event, add that S to the end of it, and that leads to a score. ACEs are based on this seminal article that was produced in the late 1990s, early 2000s. It involved the CDC and the Kaiser Permanente group sort of looking at different things that happen. And so these are the lists of ACEs here. Abuse, physical abuse, emotional abuse, sexual abuse, neglect, physical or emotional neglect, and then various forms of household dysfunction. So mental illness, a mother who's treated violently, divorce, incarceration of a relative, substance abuse. And then as we put the number of times that happens to a family together, it generates a score. And so you can see from 0 to 4 over on the left, and then as you get more and more of these ACEs, you can see what the consequences are, you know, and how we think that probably there are outcomes involving behavior that lead to health. And so ACEs are rather costly, you know, in terms of life, actually. The cost of ACEs ultimately is early death. And so you can see that people with 6 or more ACEs, that is times 6 or more of those different things that were described before, the physical abuse, the sexual abuse, the emotional abuse, the neglect, the incarceration or drug use in other people. If you total that number up, that people who had 6 or more of those in their early childhood would die 20 years earlier on average than those people who had no ACEs, you know, so an average lifespan difference there. And then you can see the quality of life for people, you know, so years of potential life lost, you know, is also significant as these numbers suggest down there. I don't want to dwell on the numbers except to say that ACEs have significant impacts across all these different potential sort of mechanisms, you know, in terms of injury, mental health, maternal health, infectious diseases, trouble treating chronic diseases, and then these risky behaviors and lost opportunities. Oh. But there are things that we can do to help prevent ACEs, you know, and that involves strengthening economic supports for families, family-friendly work policies, changing social norms to support parents, providing quality care and education early in life, and enhancing parenting skills and intervening to lessen these harms and prevent future injury. And the question is sort of, when it comes to ACEs, what's the real evidence that this could change anything? You know, I think we have sort of the studies, but as I might have mentioned earlier, I'm really thinking about some of the financial and economic costs of these programs and what the benefits might be. And so I was doing research to try to learn, well, what do we know about all of these different programs? And it turns out Washington State might be sort of the most appropriate testing ground. Back in the early 2000s, they did a pretty rigorous analysis. You'll see one of the tables here. I don't expect you to be able to read it except to see that green is good, red is bad. This was a study that basically was trying to show how we could stop needing to build prisons, you know, that they were estimating that there would be a need for 2 new prisons. This was a study back in October 2006. and maybe another prison by 2030 if the rate of incarceration continued the way that they were expecting. And so they wanted to develop and look at the evidence base for changing the needs for this prison system. And so they did the analysis and found what the cost saving would be if different interventions were tried, both for people who are already imprisoned, people who are in the juvenile system, and general programs. And so this focuses right now on the juvenile offender system. And you can see just a lot of different items on this list that could really sort of be construed as mental health treatment that help keep kids out of jail and help save costs ultimately. This is another slide that shows the prevention programs and what their cost effects were, including nurse-family partnerships, both for mothers and children, as well as a universal pre-K for low-income 3- and 4-year-olds. Now, I've already talked to you about the ACEs, and I think you can probably make some of these connections too between that list of things that we could do to improve and reduce ACEs, and also help potentially reduce the need for prisons down the road. And a lot of them overlie well. And so I think, you know, what I took away from this is that there's a lot of evidence for these programs reducing costs and ultimately having an economic benefit, as well as treating children. So much more of a return on investment than building more prisons potentially. It's also important when talking about the treatment of children, and especially that case, you know, from the Washington Post about systemic racism and how the kids who are ending up disproportionately represented in juvenile justice system are kids who are Black, Indigenous, people of color, BIPOC. This is some data about Black disparities in youth incarceration. And unfortunately, Washington State is still a place where this disparity exists. As you can see, that there has been an increase in disparity since 2001 up to 2015. And so thinking about how that affects the children who are getting care, who are developing these ACEs, and then ultimately needing to try to divert them from the prison system, from the juvenile justice system, and into more systems of treatment are really important, especially for families who don't have a lot of resources and get really desperate. And so I think that, to my mind, really speaks to President Gary's case earlier, that there is a need to intervene earlier and to provide these supports. And those are difficult in the pandemic, as that Washington Post article about this 11-year-old in Georgia sort of talks about, who, you know, has those early signs of schizophrenia. There's also a pretty big gap between inpatient psychiatry, what John Dunn was talking about 2 weeks ago, and the need for sort of increased beds, and outpatient psychiatry, basically walking into an office and seeing a psychiatrist like John or myself. A lot of levels of care. This is a list of them that kind of could exist in between sort of locked psychiatric or substance abuse treatment and outpatient care. And I'm going to sort of focus in on this green region, which is some other levels of care that I think are really important. So looking at residential treatment centers, which is to say where people go and stay overnight and get their psychiatric substance abuse or co-occurring, which means both psychiatric and substance abuse problems occurring at the same time, as well as partial hospitalization programs, basically all the services you'd get at the hospital, except you get to go home at night, and then intensive outpatient treatment programs. So that's, you know, basically more hours than just seeing a psychiatrist or a therapist during the week, but not necessarily the same intensity as partial hospital. And then a packed team, which I'll get to describe soon. Basically, all of these levels are really underfunded in the state of Washington, and we'd hope that by developing more of these systems, we can make those services more available, make them you know, cost less, essentially less than those inpatient levels of care, you know, probably more than the outpatient, you know, simply walking into an office kind of level of care. But it also is a higher intensity of service that when a patient needs it, they can get that higher intensity of service. And so I think that's an issue right now that we face in the state, that when people need that higher level of care, it's not available to them, and then they end up going to the emergency room or waiting around or going to jail and not getting, treatment at a level that's important. And instead, we sort of see the end product where they need the inpatient hospitalization. So one of the programs that I think is really important to talk about is PACT, or ACT. It's assertive community treatment. It's for patients who have severe behavior problems, SMI, serious mental illness, schizophrenia, bipolar depression, substance use, a lot of inpatient hospitalizations, for these patients. And it really means that it's a multidisciplinary team that has a lot of team members who are able to access different services for these patients: the substance abuse, the psychiatry, the other counseling, nurses to sort of manage their mental health medications or medical problems, and then also other services like vocational specialists, getting them jobs, peer counselors to meet them at a different level, and then other community supports, helping them get in touch with appropriate housing and other things. And these teams work with a team caseload rather than individual sort of caseloads or individual clinicians, so that they really are sort of baking in a team approach to any one person's difficulty. And I just think about, patients who really don't just need a medication, but need problems, like their housing or family relations to be addressed, or legal situations to be addressed, and how getting that all in one team would be really more important and powerful than a separation of all those things. These teams are able to access patients multiple times a week, and sometimes even multiple times a day, to get them the care when they're sort of ready for it. I feel like it's really important because I believe, it lowers the cost of care by providing more directed care and care that's going to address the patient's problems, rather than sort of wait on them ending up in jail or in the emergency room. And it also can help address those social determinants of health. Which brings me finally to sort of crisis intervention. And the CAHOOTS model is something many people have probably heard about in the news. It's a program that started in Eugene, Oregon about 30 years ago. It involved a 2-person team of a medic and a crisis worker with mental health training. They were intervening on 911 calls, when it was deemed that police response was not as helpful as a mental health response. And so you can see some of the examples here. Welfare checks, substance abuse problems, suicide threats, conflict resolution. CAHOOTS is a really important intervention because of the fact that individuals with mental illness oftentimes have not so good encounters with law enforcement. That frequently we see up to 20 to 50% of encounters that were fatal were with individuals with mental illness. And thankfully, Bellingham is developing a program, as Dr. Dunn was talking about when he spoke about it 2 weeks ago. So I think we're excited to see what this might lead to. I think right now the Bellingham City Council is figuring out how to potentially fund this as a project. I want to also just make note that it is not replacing the police by any means. It's really diversion, and you can see that it is saving money from the Eugene Police Department, but not replacing it. And you can see that each year that need has grown as the time has gone on. It's really only diverting 5 to 8% of calls from police, and you can hear from police officers in this article from the Eugene Register Guard that really the police view it as a service that's really important, where when they would be otherwise not necessarily helping patients to solve these mental health problems. And that brings me to sort of this bigger question, how do we know if we're doing well when it comes to treating mental illness? Is it about reducing rates of suicide? Is it about reducing the rates of ACEs? Is it about reducing the rates of imprisonment for people with mental illness or juvenile detention, or reducing disability? I think this is another important one. Neuropsychiatric illness, psychiatric disorders are the leading cause of long-term disability in the United States. and they lead both to the use of the disability system, financially, but also premature mortality. And so addressing that's really important. Getting people who have disabilities back to work, increasing their high school completion rates, lowering teen pregnancy rates, increasing maybe a taxpayer base if we're getting these people employed, are those the way that we want to mention and measure the effectiveness of this. And so, in short, my argument is that the solution to the mental health problems that I think John elucidated and that we've been talking about in the news is probably not more psychiatrists, probably not more medicine, but allocating resources that would really go longer term to benefit these mental health disparities and advocating on a local and statewide level. I think already we know that Bellingham is doing a lot to examine these things, and Washington State is doing a lot to examine these things, but I think we can do more, and in particular thinking about what is possible within this this slide to really work more towards preventing mental illness and intervening at a time when change is really possible rather than at the end when we are talking about inpatient psychiatric beds or imprisonment. So I apologize. It looks like my slideshow wanted to go automatically and I couldn't stop it from moving ahead. So I appreciate the patience that everyone had. Probably kept me on time. But I guess if there is any time left, I'm happy to answer questions and really appreciate your willingness to let me talk to you about this important topic today.
We do have time for questions. Please unmute yourself and ask questions.
Yeah, I have a question by the fellow pediatrician Steve Ban here. The ongoing struggle that we have in pediatrics, and I'm sure adult medicine as well, is that the demographics, the group of people that need and use behavioral health treatment the most are the ones who are not are the ones to whom the great majority of mental health workers, psychiatrists, and social workers are not available because the state insurance does not compensate those caregivers enough for allow them to stay in business if they take too many of those folks. And so I'm wondering whether you've heard of any movement or any push to increase the reimbursements for those services by state insurance so that the folks who need the treatment the most get them. Right now they go to clinics which do their very best, but time and again I have patients who establish with someone, say at one of the clinics, whether it's Catholic Community Services or I'm blocking on the other, but yeah, and then that person leaves, and then they establish with another one, and they leave 2 months. I mean, it's ridiculous almost. You can almost depend on that happening. So the question is there any movement or any hope that can be changed so that the people who need it most get the help from people who actually are in a position to provide the most effective long-term care?
I think that's something we continue to advocate for, among the state psychiatric societies and sort of on a national level, with these discussions about parity, because clearly when we talk about that is not, parity in the compensation of mental health treatment. I think that there are other avenues too that hopefully, we can expand upon and explore, knowing that pediatricians are oftentimes, the people who are on the front lines seeing these mental health problems when they first develop. I know that I don't want to put them on the spot, but Dr. Dunn has been a part of multiple sort of settings, and levels of care that help meet pediatricians, when they recognize the problems earlier, and these integrated care teams, where Dr. Dunn is available in a clinic for consultation, making suggestions, I think my hope is that
Right.
with the advent of psychiatry and other programs that are not necessarily location-based, that some of that just-in-time sort of consultation and intervention is going to be possible, but to your, I think I'm sort of dodging the point, that you're making, which is the compensation for the mental health care provider when it comes to state insurances needs to be more robust. And I fully agree. And I think that I think all of us would welcome that advocacy, because I think it's really important that people are able to find relationships with providers that they trust who, can provide that care and not feel like they're losing the bottom line.
Yeah, but I mean, it's clear that it would be cost effective if we could provide that. And so the frustration is why can't people at the state realize that, or maybe we're not good enough at explaining that to the obvious to those politicians or those government agencies to know that, if you will just increase the compensation, we've got all kinds of people in the community who would be able to help out with this group of patients that are getting suboptimal care now in the long term. And you're right, the consultations that we have available down at Children's that John Dunn was a part of is great, but that doesn't substitute for ongoing psychotherapy that a lot of these folks and families need. So
yeah, I totally agree. Yeah.
Can I jump in here just a second? I know we're running out of time, but I just wanted to point out, as somebody who was in private practice for 36 years, I've really come to the conclusion that individual treatment, while necessary, is really not the solution. The kinds of things that Bud was talking about in terms of programmatic prevention strategies, and he kind of skipped over the one having to do with education, but the school system affords great opportunities for prevention efforts and keeping kids in school and preventing pregnancy that would greatly facilitate the mental health of people and reduce the need for those after the fact treatments that I was providing for so many years.
true.
Okay, we're out of time. I want to thank you for a really excellent program. Everybody, a round of Rotary applause. Thank you all. Before I do my little quick COVID talk, I want to thank the people that brought this meeting to you today. As always, Sandy, who's awesome. Dominique and Sandy and I were the greeters. Shauna did AV and recording. And Shauna, you can probably turn this off anytime you'd like.